Welcome back, guys. Good morning. I hope all of you are doing fine, and myself I am doing great too. Myself, Dr. JIBRAN presents to you Simply Pathology, and today's important topic of discussion is cell injury part 4. Hope you all have been enjoying my previous videos, and if you're enjoying, please don't forget to subscribe and share, and do comment if you have any doubts. Okay, thank you so much. Let us start. Today we are going to start with free radicals and oxidative stress. So we have already read something about the free radicals, and today we are going to read in details about the free radicals. Okay, so my first question to you is, what are free radicals? So basically, any molecule inside the body, okay, which is having an unpaired electron, okay, becomes highly reactive, okay, and they will attack the nearby phospholipids, nucleic acid, carbohydrates and proteins. So any such molecule which is unstable and is going to attack any nearby phospholipid, nucleic acid or carbohydrates, they are called as free radicals, and they are a major source of cell injury. Now they are going to cause cell death not only by necrosis but also apoptosis. So they cause cell death by necrosis and apoptosis. And oxygen derived free radicals are called as a reactive oxygen species, whereas nitrogen derived free radicals are called as reactive nitrogen species. Now what is the source of these free radicals? From where are these free radicals coming? So there are many chemical or radiation injury. Again, there can be ischemia, reperfusion injury, cellular aging, microbial killing, cancer, as well as inflammatory reaction. So all these different kinds of cell injury can be a source of free radicals. Now let us look at the generation of free radicals, how they are generated inside our body. So firstly, oxidative and reductive reactions are taking place during the normal metabolic process in our body. So it is during these metabolic processes that free radicals are being generated. Secondly, UV rays as well as X-rays. So these radiant energies, okay, whenever they are acting in the water molecules, they are going to convert that into H plus and OH negative ions, and hydroxyl ions, that is OH negative ions, they are free radical. So again, UV rays and X-rays, they are a source of free radicals in our body. Again, the different kinds of inflammatory reactions which are taking place in our body, as we have read before in inflammation chapter, that activated leukocytes, okay, they always release reactive oxygen species and nitrogen species so as to combat the bacteria, and in the process they are also causing damage to our body tissues. Again, we are having certain metabolism of exogenous substance. So here what is happening, any exogenous substance, okay, when we are inhaling or when we are taking inside or ingesting any exogenous substance, for example carbon tetrachloride, CCl4, so inside our body they are getting metabolized into another reactive free radical that is called as CCl3. I want to remind you that this is not an oxygen, okay, reactive oxygen species, but it is just a free radical, okay, because this is not derived from oxygen, therefore it is not an ROS. Now let us look at the transition metals in our body. Now they are also a basic source of free radicals in our body. For example, in the presence of hydrogen peroxide, iron Fe+2 gets converted to Fe+3, and in the process they are generating OH and OH negative hydroxyl ions. This reaction is called as Fenton's reaction. So we call this reaction as Fenton's reaction, okay. And lastly, our basic source is the nitric oxide. Now what is the source of nitric oxide? Our endothelium, neurons and the macrophages. We have already read before the sources of nitric oxide in the chapter on inflammation. Okay, so from there we are getting an enzyme called as nitric oxide synthase, and nitric oxide is being synthesized in these basic sites. So from nitric oxide, in the presence of superoxide anion, we are going to get a reactive nitrogen species which is a highly reactive RNS called as peroxynitrite, ONNO negative, that is peroxynitrite. Now which are the important free radicals? Okay, there are certain important free radicals that we are going to study. What are those? Number one, we are having superoxide anion, hydrogen peroxide, hydroxyl anion, and we are having peroxynitride. Let us see individually. So individually what we are going to see, we are going to see that particular free radical, we are going to see how they are being produced and what is the mechanism of inactivation of those free radicals. So number one is the superoxide anion. So what is the mode of production of this anion? By incomplete reduction of oxygen during oxidative phosphorylation by phagocyte oxidase inside the leukocyte. So this is the method of production of superoxide anion. And how are they inactivated? So in the presence of an enzyme called as superoxide dismutase, superoxide gets converted to hydrogen peroxide and oxygen. Okay, let us look at the second free radical, that is hydrogen peroxide. Already we have seen that superoxide in presence of superoxide dismutase gets converted into H2O2. That is the mechanism of inactivation of superoxide. But this same mechanism acts as a mechanism of production of H2O2. So when superoxide, okay, it undergoes spontaneous dismutation, okay, in the presence of superoxide dismutase, it will get converted to hydrogen peroxide and oxygen. Now what is the mode of inactivation of hydrogen peroxide? So as we know, hydrogen peroxide can be inactivated in two ways depending on the location. So in the peroxisomes, there is catalase enzyme which is going to break down hydrogen peroxide into water and oxygen. Whereas in the cytoplasm or cytosol, in the presence of an enzyme glutathione peroxidase, hydrogen peroxide gets converted to water and oxygen. Okay. Looking at the third important anion, that is hydroxyl ion. Okay, so hydroxyl ion, if you see, what is the mechanism of production of hydroxyl ion? If we see, so there are three basic mechanisms. Okay, one is in the presence of water, okay, and UV rays, all the rays and radiation, the water will undergo hydrolysis and give rise to hydroxyl ion. Secondly, from hydrogen peroxide, as we have already seen before, there is a reaction called as Fenton's reaction, which requires iron, and H2O2 gets converted to hydroxyl ions. Also from superoxide the superoxide anion, they can also get converted directly to hydroxyl ion. So there are three basic ways of production of hydroxyl. One is from water by radiation, then we are having hydrogen peroxide by Fenton's reaction, and then from superoxide ion. Now what is the mechanism of inactivation of hydroxyl ion? Now hydroxyl ion in presence of glutathione peroxidase can get converted to water. Okay, the last free radical is peroxynitride. Now we have already seen the production of peroxynitride. In presence of superoxide, the nitric oxide will get converted to peroxynitride, as we have seen before. And what is the mechanism of inactivation? Now this peroxynitride, in the presence of peroxyredoxins, which is present inside the cytosol as well as in the mitochondria, it gets converted to a mild acid, that is the nitrous acid actually, yes, the nitrous acid. So these are the four important free radicals that you have to know. Now how are these free radicals removed from our body? So remember, free radicals are basically produced in our body to combat the microbes and the injurious agent. And our body also has certain mechanism to inactivate these free radicals after their job is over. So what are these mechanisms that we have in our body? Number one, we are having antioxidants in our body. These are the vitamins, vitamin A, vitamin C, vitamin E. So these you can remember as ACE. Again, as we saw that iron and copper, they can be a source of production of free radicals in certain reactions, as we have seen. Okay, so therefore iron and copper, they are never present in the free form. Our body has different kind of proteins to bind these free iron and copper. So we are having transferrin, ferritin and lactoferrin. These are basically binding the iron, okay, and we are having cellular plasmin that binds with copper. Okay, so these basic plasma proteins, they do not allow the iron and copper to be available in the body in the free form, because if they are available, they will participate in certain reactions and they are going to produce free radicals. For example, we have seen the Fenton's reaction. And thirdly, we have different kinds of enzyme, as we have already seen before. Superoxide dismutase is the one which is actually eliminating superoxide anion. Now catalase is one enzyme which is also eliminating another free radical that is called as hydrogen peroxide. And we are having glutathione peroxidase, okay, which is going to inhibit hydrogen peroxide and hydroxyl ions. Now one more thing I forgot to tell you, that among all these free radicals, okay, the hydroxyl ion is the most powerful free radical. It is the most powerful free radical. This can come as an MCQ. Moving ahead, what are the pathological effects of free radical? Now we have already discussed in details in mechanism of cell injury in membrane damage. What are the effects of free radicals? But I am going to enumerate over here also. So free radicals are causing basic injury by three basic mechanisms. One is they are causing membrane damage by lipid peroxidation. Second, they are also modifying the proteins by the breakdown of protein as well as the misfolding of the proteins, and they are causing the DNA damage and inducing mutations. Okay. Now the next topic is very important, but before I go into the next topic, I would like to speak something about the waste disposal. Already we have read about waste disposal in chapter number 1, that is cell as a unit of health and disease, but we are just going to revise that how the waste from our body is being metabolized at the cellular level. So we are having lysosomes, and inside the lysosomes we are having autophagy and we are having heterophagy. So inside the lysosomes we will get disposal by autophagy and heterophagy. Whereas at the level of proteasomes, okay, we are having several mechanisms. At the level of the cytosol and at the level of the endoplasmic reticulum. So at the level of the proteasomes, if you see, the waste disposal is different depending on the location. If there is excessive amount of misfolded proteins present in the cytosol, then there will be proteasomal degradation of these misfolded proteins into peptide fragments. Whereas if abnormal or misfolded proteins accumulate in the endoplasmic reticulum, there we will get what is called as ER stress, that is endoplasmic reticulum stress or unfolded protein response, wherein the cell death will be occurring by the mechanism of apoptosis. So you have to remember that waste disposal can occur at two levels. One is the lysosomes, another one is the proteasomes. At the level of the lysosomes, we are having autophagy and heterophagy, whereas at the level of the proteasomes, excessive misfolded proteins at the level of the cytosol will undergo degradation into the peptide fragments by the proteasomes, whereas at the level of the endoplasmic reticulum, the excessive misfolded protein is going to trigger ER stress or unfolded protein response, wherein the cell death will occur by apoptosis. Now, the main or the most important topic over here is endoplasmic reticulum stress response or unfolded protein response. Again, this is a very important exam question. So, first we have to understand that the newly synthesized protein inside the cell, basically this synthesis occurs inside the endoplasmic reticulum. Okay. Second thing is that once these proteins are synthesized, it is the job of another proteins called as chaperones, which will take care of folding that proteins. Okay, so chaperones' main function is to ensure that the proteins are properly folded. After proper folding of the proteins only, they will mature and give rise to mature folded proteins. So this is what happens in a normal situation. So let us see, okay, what happens in abnormal situations. So for example, now there is a situation where a large number of misfolded proteins are being developed inside the cell, or proteins are misfolded. Okay, so what are these conditions wherein the proteins are getting misfolded? So these are metabolic alterations like ischemia, hypoxia, hypoglycemia and hypoxia. Then we are having genetic mutations in the proteins. Which proteins? Proteins which are responsible for folding. Okay, these are the chaperones. Thirdly, we can have certain viral infections, and fourthly, we can have chemical insults. So all these different kinds of insults can lead to misfolding of proteins. So suppose now there is an excess amount of misfolded proteins. Now what will happen inside the endoplasmic reticulum? When excess amount of misfolded proteins are going to accumulate, they are going to trigger unfolded protein response. So let us see what is this unfolded protein response. So what happens whenever, so unfolded protein response or ER stress response always occur at the level of the endoplasmic reticulum. So once we are having an excess amount of misfolded proteins, they are going to trigger a cellular adaptation. So the cell will now try to adapt to this excess amount of misfolded proteins by two basic mechanisms. One is it will decrease the synthesis of such misfolded proteins. How? By reducing translation. Secondly, they are going to increase the production of chaperones. Now, as we all know, chaperones are the proteins which are responsible for proper folding of the newly synthesized proteins. So this is called as cellular adaptation. So the cell will first try to correct the situation. Okay. So what happened now? Even after cellular adaptation, there was excess amount of misfolded proteins. That is, the protein folding demand exceeded the folding capacity of the cell. So there was a failure of adaptation. Okay. So once there was a failure of adaptation, there is a release of caspases from the endoplasmic reticulum into the cytoplasm, and that, as you all know, will trigger the cell death by apoptosis. Just you have to know one thing, that this response is occurring at the level of the endoplasmic reticulum. Let us move ahead. Now, what are the examples of the diseases which are caused by misfolding of the proteins? So if you see here, we are going to discuss the various diseases, the affected protein, and the basic pathogenesis behind that. So first of all, the disease is cystic fibrosis. Herein the affected protein is CFTR protein, and the basic pathogenesis over here is a defective chloride transport. Secondly, we are having familial hypercholesterolemia. Here if you see, the affected protein is LDL protein, and the basic pathogenesis over here is hypercholesterolemia. Thirdly, we are having Alzheimer's disease. Here the basic affected protein is A-beta peptide, and the basic pathogenesis is accumulation of abnormal proteins. Then we are having Creutzfeldt-Jakob disease. Herein the affected protein are the prion protein. So we are having abnormal prion protein, and there is an accumulation of these abnormal proteins. Then we are having alpha-1 antitrypsin deficiency. Here the affected protein is alpha-1 antitrypsin, and basic pathogenesis over here inside the lungs, the deficiency of this enzyme will lead to emphysema, and inside the liver it will lead to a storage disease. And lastly, we are having Tay-Sachs disease, wherein the affected protein is hexosaminidase beta subunit, and the basic pathogenesis is the storage disease. We are having gangliosidosis. Okay. Now we are going to discuss about the intracellular accumulation. So there are various intracellular accumulations that we are having. Let us see. So these intracellular accumulations, they can be of four basic types. We can have accumulation of lipids, we can have accumulation of proteins, we can have accumulation of pigments, and we can have accumulation of carbohydrates. So at the level of the lipids, okay, what are the intracellular accumulations that we are watching? We are having steatosis or fatty change. We are having deposition of cholesterol or cholesterol ester. At the level of proteins, we are having reabsorption droplets, plasma cell dyscrasias, accumulation of misfolded proteins, amyloidosis, and accumulation of cytoskeletal proteins. Now the different kinds of pigments, okay, pigments can again be divided into two main types. They can be exogenous or they can be endogenous pigment. So exogenous pigments are carbon and even the tattooing that we are having, and the endogenous pigments are lipofuscin, melanin, and hemosiderin. Now the carbohydrates in our body that accumulates is basically the glycogen accumulation. Moving ahead, before we go into the individual accumulations of different things in our body, we are first going to see what is the basic mechanism of accumulation, why there is accumulation, okay, which is occurring in our cells, why accumulation is occurring. So there are four basic mechanisms. Number one, because of an inadequate removal of a normal substance. For example, fat is accumulating inside the liver and the condition is called as a fatty liver or fatty change. Here there is an abnormal metabolism and transport. The second thing which can occur is there is an accumulation of an abnormal endogenous substance. For example, there is a production of an abnormal protein inside our body. For example, mutated forms of alpha-1 antitrypsin. Now, alpha-1 antitrypsin is an endogenous protein. It is performing some function. But sometimes, because of some mutations, we are having a mutated form of alpha-1 antitrypsin protein. So here the basic defect is lying in the protein folding and transport, which is giving rise to the mutated form of alpha-1 antitrypsin. Thirdly, we can have accumulation of a metabolite because of lack of an enzyme. For example, there is a particular enzyme, okay, which is responsible for metabolizing a particular metabolite. Okay, in the absence of that enzyme, that particular metabolite is going to accumulate inside our body. Example, lysosomal storage disease. And fourthly, we are having the deposition of abnormal exogenous substance. For example, when we are inhaling the carbon particles or silica particles, okay, they are going to go and deposit in the lungs. We don't have any facility for degradation of these molecules. For example, when you are inhaling the carbon particles, what is going to happen? These carbon particles are going to be phagocytosed by the macrophages, but the macrophages are not able to degrade them. There is no particular enzyme or no particular mechanism. So the fourth mechanism is deposition of abnormal exogenous substance. Coming number 1 to lipid accumulation. Now, lipid accumulation can occur in two particular ways. But before I go into the lipid accumulation, first of all, I want to tell you the full form of certain points. Now, TG stands for triglycerides. Okay. C stands for cholesterol, CE stands for cholesterol ester, and PL stands for phospholipids. So lipid accumulation number 1 that occurs is steatosis or fatty chain. So what is steatosis and what is a fatty chain? So whenever there is an abnormal accumulation of triglycerides within the parenchymal organs, okay, by parenchymal organs, the most common one is the liver. And there are other parenchymal organs also, for example, the heart, muscles, and the kidney. Now, what is the cause of steatosis? Okay, they are obesity, diabetes mellitus, malnutrition, alcohol abuse, non-alcoholic fatty liver disease. So histopathologically, what you will see that inside the cell we are having certain clear spaces, we are having intracellular vacuoles, and we will also see that the nucleus is pushed to the periphery. Let us come to the second important lipid accumulation, that is accumulation of cholesterol and cholesterol esters. So we are having four basic forms. One, we are having atherosclerosis. In atherosclerosis, what happens that cholesterol and cholesterol esters is going to accumulate inside the smooth muscle cells and the macrophages within the atherosclerotic plaques. And these macrophages and smooth muscles containing these lipids is called as the foam cell. Okay, when we read about atherosclerosis, we will read in details about that. The second point is xanthomas. Okay, xanthomas. You will see some people, okay, obese people are having certain xanthomas. Okay, there are certain accumulations in the eyelids, okay, in various body parts, in the necks, in the shoulders. Okay, what are these xanthomas? These xanthomas are nothing but these are clusters of foamy macrophages containing cholesterol in the subepithelial connective tissue of the skin or tendon. Then we are having cholesterolosis. Again over here we are having cholesterol laden macrophages in the lamina propria of the gallbladder. Then we also have Niemann-Pick's disease. It is a lysosomal storage disease. Again over here what is happening? Cholesterol is accumulating in multiple organs. With this we complete lipid accumulation. Let us look at one diagram. So this is the diagram. This is how fat accumulation will look like. So if you see, there are multiple spaces, clear spaces, intracellular vacuoles, and you see over here how the intracellular vacuole has pushed the nucleus towards the periphery. This is called as the fatty chain, and the most common organ which is involved is the liver. Now let us look at the protein accumulation. Now, proteins basically appear as rounded eosinophilic droplets or vacuoles or aggregates inside the cytoplasm. Usually they are intracellular. with an exception. Okay, in amyloidosis, the protein accumulation is intracellular as well as extracellular. Okay, it is not only intracellular, it is both intracellular as well as extracellular. Okay, under electron microscopy, the proteins appear as amorphous fibrillar crystalline. Okay, now let us look at the different types of protein accumulations. Number one, we are having reabsorption droplets. Now, such reabsorption droplets are seen in the proximal renal tubules in the kidneys. Now, what is happening? Let me explain you. So, in any kind of a renal disease which is characterized by proteinuria, which is associated with proteinuria, so what happens that the protein is getting filtered across the glomerulus. Okay, so once these proteins are coming inside the tubules, they are reabsorbed into the tubular cells, and these proteins, excess amount of proteins which are reabsorbed inside the tubules, they form reabsorption droplets. Okay, when we look under the microscope, they appear as pink hyaline droplets. Now, plasma cell dyscrasia. So what do you mean by plasma cell dyscrasia? So all the diseases or all the conditions or tumors of the plasma cell is called as plasma cell dyscrasia. So usually in plasma cell dyscrasia or disease, there is an increased synthesis of immunoglobulins, and these immunoglobulins are synthesized within the endoplasmic reticulum, leading to hugely distended endoplasmic reticulum, okay, which appears as large eosinophilic homogeneous inclusions within the endoplasmic reticulum, and these distended endoplasmic reticulum is called as Russell bodies. Now you have to understand this very importantly. These Russell bodies are very important. Okay, now there are important things over here. Other forms are what? We can have defective intracellular transport as well as secretion of critical proteins. Okay, what is the example? We are having alpha-1 antitrypsin deficiency. So here there is mutation which is taking place in alpha-1 antitrypsin. Okay, now this will lead to accumulation of alpha-1 antitrypsin inside the endoplasmic reticulum of the hepatocytes, and that is going to trigger unfolded protein response, leading to ultimately cell death by apoptosis. Again, we can have accumulation of abnormal misfolded protein, both intra and extracellular. Example is amyloidosis, as I have already mentioned before, and there can be accumulation of cytoskeletal proteins. So first we have to understand what are these cytoskeletal proteins. We are having microtubules, which size of which is 20 to 25 nanometer. We are having actin filament, size is 6 to 8 nanometer. We are having myosin filament, size is 15 nanometer, and we are having intermediate filament, size is 10 nanometer. So all these basic tubules that we are watching or we are looking at, okay, these are the normal cytoskeletal proteins. Now intermediate filament is one which can accumulate in various body parts. So we are having different types of intermediate filaments. We are having the keratin filament, which is basically present inside the epithelial cell, and accumulation of the keratin filament can be seen in alcoholic liver disease. Okay, and we call them as alcoholic hyaline. We call them basically as alcoholic hyaline. Then we are having certain neurofilaments. Neurofilaments are basically seen in cases of neurons. Okay, so these neurofilaments will accumulate inside the neurons and lead to neuronal cell death, and this is seen in Alzheimer's disease. Again, we are having Desmin filament. Now such filaments are going to accumulate in the muscle cells. Again, we are having Vimentin filament. Okay, these are connective tissue filaments, and these basically accumulates in connective tissue diseases. And we are having glial filaments which are going to accumulate inside the astrocytes. Okay, now what is hyaline change? See, the homogeneous glassy pink appearance under microscope in H&E staining is called as a hyaline change. It is not a disease, it is just a descriptive term. We can have intracellular hyaline, we can have extracellular hyaline. So intracellular hyaline, the examples of those we have already seen, like the reabsorption droplets, Russell bodies, alcoholic hyalines, and the extracellular hyalines we can see in long-standing hypertension or diabetes mellitus, wherein we are seeing hyaline arteriosclerosis. So what is happening in those conditions? Because of damage to the vessels, okay, the plasma proteins are extravasating or coming out of the vessels, and they're depositing on the cell membrane. Okay, so there is a basement membrane material deposition in the walls of the arterioles. Okay, plasma proteins deposit in the walls of the arterioles, and there is a thickening of the walls of the arterioles. This is called as hyaline arteriosclerosis. So let us look at this basic diagram. This particular change is called as hyaline change. So see how this is an artery. See how there is a thickening of this walls of this artery, and see how the lumen has become narrow. Okay. Looking at the other basic image, now here we are having a proximal convoluted tubules of the kidney. Now over here what we see, the arrow marks is basically showing the round eosinophilic protein reabsorption droplets, okay, that we read about before. So these are protein accumulations. Again, what we can see over here is the Russell body. So these cells are having accumulation of excess amount of immunoglobulins inside the endoplasmic reticulum, okay, as we can see over here. So these are the plasma cells inside of which the endoplasmic reticulum has been distended. Okay. Now we will also see one important part. Now here we can see the amyloid deposition which is occurring inside the heart. Now I told you before that amyloid deposition, now this is appearing as amorphous fibrillar, okay, and they are present both extracellular as well as intracellular. So amyloid deposition in the heart in between the cardiac myocytes. Let us look at the pigment accumulation. Now pigments, they can be both normal, example melanin, or they can also be abnormal. Now pigments are nothing but they are colored substances. They can be both exogenous as well as endogenous. We have already seen in the exogenous pigment we are having most commonly the carbon particles. Now these are air pollutants actually. They are accumulating inside the macrophages in the lungs, leading to blackening of the lungs, and the term we use is called as anthracosis. In coal workers, if you see, increased amount of carbon will induce a fibroblastic reaction that is called as an emphysema, and that will ultimately lead to what is called as coal workers pneumoconiosis. Again, tattooing. What is tattooing? When we have a tattoo inside our bodies, it is nothing but localized exogenous pigmentation of the skin. Now let us look at the endogenous pigments. Okay, before we go into that, here what we can see is, if you see, this is the anthracosis of the lungs. Okay, this is the anthracosis of the lungs. Here we can see how the carbon particles have accumulated inside the macrophages inside the lungs. Okay, now the endogenous pigment, the first most important is lipofuscin. Now lipofuscin is basically an insoluble pigment. Okay, they are basically the polymers of phospholipid in complex with the protein. They are the products of lipid peroxidation of polyunsaturated lipids of the intracellular membranes, and they are the basic telltale sign of free radical injury. Moving ahead, if you see, the term lipofuscin has been derived, okay, from a Greek word, fustus meaning brown, also known as brown lipid. Now yellowish brown, they are yellowish brown pigment, finely granular, cytoplasmic, and often perinuclear pigment. They are seen in the liver and heart of aging patients, and also they are seen in cancer cachexia. So this was the first endogenous pigment, that is lipofuscin. The second pigment is the melanin. It comes, the term melas meaning black. Okay, it is basically derived from an essential amino acid, that is tyrosine, in presence of an enzyme tyrosinase to form dihydroxyphenylalanine. It is the only endogenous brownish black pigment, and it is a normal pigment in our body. Another abnormal black pigment which is present in our body is called as homogentisic acid, and it is basically an abnormal pigment, and the disease is called as alkaptonuria. Okay, whenever this will come in urine, it is called as alkaptonuria. If this will get deposited in the tissues, we called as ochronosis. Now the last endogenous pigment is the hemosiderin. As the term suggests, they are derived from the hemoglobin. They are golden yellow, brown, granular pigment, okay, crystalline pigment, and it is one of the major storage form of iron. Now, whenever there is an excess amount of iron inside our body, the normal storage form of iron is ferritin. So whatever we are eating, okay, that is coming normally inside our body, they will be stored as ferritin. And this ferritin will aggregate to form hemosiderin. But you have to remember, normally only very small amount of iron will be stored as hemosiderin. Okay, and hemosiderin, the iron inside the hemosiderin, or the hemosiderin is basically stored inside the macrophages, and these are basically the breakdown form of RBCs, iron which is coming from the breakdown of RBCs. So normally this hemosiderin, it accumulates the iron which is coming from RBC breakdown, and normally hemosiderin is present in very less amounts. So localized or systemic excess of iron is always stored in the form of hemosiderin. So whenever there is a breakdown of RBC because of excessive hemorrhage or any other cause which is not a normal cause, that excess amount of iron will be stored in the form of hemosiderin. So we can have a local and we can have a systemic accumulation of iron. So what is the localized excess of iron? Let us see. So whenever there is a hemorrhage inside the tissues, for example a common bruise, so the extravasated RBCs will be phagocytosed by the macrophages, and that will be broken down, and then the iron will be recovered and stored as hemosiderin. Okay. Again, there is a systemic excess of iron that occurs in hemochromatosis. That is, whenever there is an excess amount of iron absorption, that condition, that disease is called as hemochromatosis. We can also have excess amount of iron from RBC breakdown that occurs in hemolytic anemia. Again, this is an abnormal condition. Thirdly, whenever we are having a repeated blood transfusion, okay, for example in thalassemia, our body excess amount of iron, okay, will be there inside our body, and that will be converted to hemosiderin, and that hemosiderin will be stored in different kinds of body organs, leading to systemic hemosiderosis. Okay, so the next kind of accumulation that we are going to read now is the glycogen accumulation. So as we have read about the different kinds of accumulation before, now the last kind of accumulation that we are going to see is the glycogen accumulation. Now what happens that excessive amount of intracellular deposition of glycogen occurs due to abnormality in either glucose or glycogen metabolism. Now if you see under the microscope, there appear as clear vacuoles, okay, and we also call it as fixation artifact because during tissue processing, okay, this glycogen is washed off by the fixative that we used. Now which is the special stain that we used for glycogen staining? So to highlight the glycogen under the microscope, we are using PAS, called as the periodic acid Schiff reagent or best carmine, and under the microscope they give a rose to violet color. Now glycogen accumulation occurs in diabetes mellitus as well as in glycogen storage diseases. Moving ahead, we see the last leg of our lecture, that is the calcification. Now what is calcification? So pathological calcification is the abnormal tissue deposition of calcium salts together with smaller amounts of iron, magnesium and other mineral salts. Now there are two basic kinds of calcification that we have to read. One is dystrophic calcification, another one is metastatic calcification. So what is the basic difference between these two types of calcification? So under dystrophic calcification, the calcium deposits in the dead or degenerated tissue, whereas in the metastatic calcification, the deposits of calcium salts occur in the normal tissue. Now in dystrophic calcification, the calcium metabolism is normal, whereas in metastatic calcification, the calcium metabolism is deranged. Now also in dystrophic calcification, the serum calcium levels are normal, whereas in metastatic calcification, the serum calcium levels are raised. There is a hypercalcemia. Now let us look at the dystrophic calcification. Now dystrophic calcification occurs in areas of necrosis of any type, okay, or in areas of damage. Now example, calcium deposition occurring in the atherosclerotic plaques or in the damaged heart valves, okay. Ultimately, because of calcium deposition, there can be organ dysfunction. So macroscopically means when you look with your naked eyes, what do you see? The calcium deposits appear as fine whitish granules or clumps, which is often felt as gritty deposits. And microscopically, that is under the microscope, if you see under H&E stain, they are bluish, they are basophilic, amorphous, granular, sometimes clumped appearance. And after a long time, they can also be a bone formation. Now one important MCQ is that in some tissues, okay, in some tissues, these depositions take the shape of Samoma bodies, wherein they are arranged in concentric layering. So there is a progressive calcium deposition in outer layers, creating a lamellated appearance. This is what is the Samoma bodies. And many tumors are associated with psammoma bodies. So this is an important MCQ. So which tumors are associated with psammoma bodies? We are having papillary thyroid cancer, papillary renal cell carcinoma, ovarian papillary cancers, and meningiomas. Now, one important MCQ again. One second example of dystrophic calcification is asbestos bodies. So these are nothing but these are beaded dumbbell-shaped asbestos bodies which occurs in asbestosis of the lungs, and they are composed of calcium and iron. They are long, slender, and they are dumbbell-shaped. Okay. So this basic H&E stain, it highlights under the microscope how calcium or calcification occurs. So see, these appear as basophilic calcium deposits or bluish deposits. Okay, also grossly, okay, if we see how calcification looks like whitish granular deposits. Here we see calcification in the diseased aortic valves. Also, these are psammoma bodies. So see how these looks like. They look like concentric layering, concentric deposition of calcium around the tumor particles. And these are the classical asbestos bodies. So you can see they are dumbbell shaped and they have beading at the ends. Now we have already read about the dystrophic calcification. Now we are going to read about metastatic calcification. So metastatic calcification is associated with hypercalcemia, as we have seen before, and there are 4 basic causes of hypercalcemia which is associated with metastatic calcification. So there can be an increased secretion of parathormone. So this we can see in parathyroid tumors, which is hypersecreting the parathormone. Again, we can have ectopic secretion of parathormone from malignant tumors. For example, we are having a tumor of the lung. There is a tumor which is secreting a parathormone-like peptide, which is not secreting parathormone, but it is secreting a basic peptide who is functioning as a parathormone. So all of them is leading to hypercalcemia and ultimately calcification or deposition of calcium in the tissues, leading to metastatic calcification. The second important mechanism of hypercalcemia is resorption of the bony tissues. Means calcium is getting reabsorbed from the bony tissue. So it can happen in 3 basic scenarios. Firstly, it can occur secondarily to the primary bone tumors, for example multiple myeloma or leukemia. Again, it can occur basically secondary to skeletal metastasis. For example, there is a metastasis of a breast cancer to the bones, to the skeleton, and because of that tumor there is an increased resorption of bony tissue and hypercalcemia leading to metastatic calcification. And third condition is increased bone turnover that occurs in Paget's disease. So all these 3 comes under resorption of the bony tissue. The fourth important cause of hypercalcemia is vitamin D related disorder. For example, there is a vitamin D intoxication. Again, there is sarcoidosis. Again, there is idiopathic hypercalcemia of infancy, also called as Williams syndrome. And the fourth important cause of hypercalcemia is retention of phosphate, leading to secondary hyperparathyroidism. Now, what are the other causes of metastatic calcification? So we can have aluminium intoxication in a chronic dialysis patient. We also have milk alkali syndrome, which occurs because of an excessive ingestion of milk or antacids like calcium carbonate. Now, metastatic calcification involves the interstitial tissues of our gastric mucosa, kidneys, lungs, arteries and veins. And usually such calcification causes no dysfunction, but when massive deposition will occur, it can lead to organ damage. Example, in the kidneys, if excess amount of calcium is going to deposit, it will lead to nephrocalcinosis. So thank you very much guys. Thank you for watching my videos. I wish that you are learning from my videos. And thank you for subscribing to my channel, commenting, and please don't forget to share with those who are in need. Thank you very much. Do enjoy my videos.